The Core 360 belt is the best aid to train the abdominal wall. The Core 360 is a patent-pending, first-of-its-kind training belt that helps you move, breathe, and perform better. We use the Core 360 belt with almost every patient at Winchester Spine and Sport. The biofeedback is second to none, and it's an amazing way to teach proper respiration and can be even used during higher-level movements in the gym. Teaching proper respiration is about as fun as a rash, but with the Core 360 belt, you take all the headaches away. Visit core360belt.com and use the code GESTALT for 10% off all belts, Ohmtrack sensors not included. Again, visit core360, CORE360BELT.com and use the code GESTALT for 10% off. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are in Ann Arbor, Michigan. Brett, we're in Detroit Rock City this morning. I had to come over. We got a special guest tomorrow, but we couldn't leave Ann Arbor without sitting down with the one, the only Dave Oliver. So, Dave, you're an international MDT instructor. How the hell did you wind up in Michigan? You're from the UK, correct?
Yep, Michigan. Well, I came over in 1995. That's making me feel old now. I graduated from the University of Bradford in the UK. I was worked for a few years, and back in the mid-90s, there was a big shortage of therapists over in the US. So I was applying to come to the US, and there was a bunch of us in the hospital system that I worked at. We were all applying. There's probably about 10, 12 people. They had recruiters coming over to the UK and actually just basically hosting recruitment things to actually bring therapists over because they were so short over here. So I started looking into it, and I started the process of getting all my credential stuff to transfer over here. The difference is we have a different education system. So when I went to PT school, I went there when I was 18. And I went straight into the PT program. Wow. We don't spend 4 years doing prerequisites. We don't do anything like that. We go straight in. So lacking those 4 years was a barrier to coming over here. Because if you want to, a lot of states, if you want to get a license for those states, they will look at your credentials and say, well, you don't have sufficient undergraduate study. Your graduate study is fine, but you need to go back and take these classes. Actually, a few years ago, I applied to get a license in North Carolina, and they were saying, "Oh yeah, well yeah, we'll give you a license, but you got to take a trigonometry class, a humanities class, start looking at some art,
I'm out at that
and
point.
stuff like that." And
Classic higher education,
are you kidding
right
me?
there.
I'm not. Yeah, so I don't want to do that. Anyway, so back in the mid-90s, though, there was such a shortage. About half a dozen states they cut the red tape. Michigan was one of those states. And I started the application process, and then I was really enjoying what I was doing in Birmingham in the UK. And I was like, well, why do I leave right now? Things are great. And anyway, so then, a year goes by, my job starts to kind of change a little bit, and then I'm about to start thinking about reapplying. And then I get a letter from one of the companies that I'd worked with, and they just said, Michigan calling. And they flew me over to Ann Arbor for a week, gave me spending money, took me out for dinner, and showed me around, and then I was like, all right. And at that point, they were like, okay, so we've already spent some money on getting him here, so we'll look at getting him a job. So then that was in the summer of '95, and then by about Thanksgiving, I touched down in Detroit.
I love it.
Dave, what was your epiphany moment in your career when you got exposed to MDT, or where you began that training?
Well, I worked in Birmingham with a girl called Julie Kilby, who had taken Part A and Part B, and she was actually had a research post in the UK, and she was actually doing research on the McKenzie method. In fact, I believe she's published, I think, in the original cervical text. She's quoted in the cervical text. But I was just talking. I talked to her, and she was kind of interesting. And I was in the UK, and I was taking Syriax courses. I'd taken Maitland courses. And I was going through the Syriacs program when I first came over here. Now, in the UK, you have a lot more in-service education. You have, like, every week you're having, like, a senior therapist kind of help training you and help you going through stuff. And when I came here, it was like, yeah, you're working. Hey, there's your job. Start working. So I was like, all right, well, I'm taking Syriac. So basically, then I thought, McKenzie kind of appealed to me. So I took Part A here 1 year. Then I went back to the UK for a vacation, took my Syriacs B. Then I came back here and took McKenzie B. I used to use McKenzie for the spine, Syriacs for the extremities.
That's not a bad mix, though.
Yeah, it was good because the thing I liked with Syriacs was it's very McKenzie. It's a real good foundation, real good structure.
Right.
Testing this structure, and I really liked that. Syriacs for the spine was, just crank on the neck and force it. If it doesn't go to the right, then just manip it that way. And that was a little bit kind of like, I'm not too sure about that. So I took A and B.
Who taught your first A?
Phil Birchall, Canada. A and B. But the turning point was Habawi's Part C. Because I went to Chicago and Scott taught that Part C. And I think I said something stupid like, what do you do with the non-McKenzie patients? And he said there are none. And it says this, we use this system. He was in Austin at that point, and he goes, we have the best outcomes, we have the lowest number of visits, we have the highest satisfaction of the whole hospital system. And then just watching him, I was like, he's onto something here. So then, D. Then I took C again with Robert Metcalf. And then as soon as I became credentialed, it was like, what do I do now?
Right.
Well, where do we go now? This can't be it. And very, very quickly, it was like I put my application in for the diploma program.
One of the hallmarks of the McKenzie courses is you guys see patients, and you only see patients one time. You follow up with them throughout the weekend, which I think is just brilliant.
Yeah.
Because we always say like anybody can be a hero one time. So then when you're forced to follow up with them 24 hours later, I think that makes a huge difference. In saying that, you're fresh off teaching this weekend in California.
Yeah.
So we're dying to ask you. Tell us about your 2 or 3 cases that you had this weekend.
Yeah, well, 5 cases.
Oh gosh.
Yes.
Yeah, less teaching that way though.
Yes. It's Well, this is a part. I just taught a Part C. For Part C's, I like to get a couple of spines, and I like to get 3 or 4 extremities on them. We unfortunately, which is a common occurrence, the extremities that I saw, 2 of the 3 were spines. So it's like, which is very common.
But, neat in another way.
We see that all the time. Probably more so with the Part Ds, because you get the first couple of necks that come into the class, then they bring 4 shoulders, and then those 4 shoulders, 3 of them turn out to be necks.
Right.
You quick screen, and very, very quickly you start going into the. I guess the 2 interesting patients, but one was not an English speaker, was Spanish and didn't speak a word of English, but was interesting. One patient had anxiety disorder, sat in front of the class, and wasn't too into it. But
right in your wheelhouse.
Yeah, but the one patient, I think the one interesting one was a patient with knee pain, with loss of terminal knee extension, loss of passive flexion, primarily pain located just in the knee. Also had some back pain. But didn't have a marked loss of spinal motion. Is that going to bother you?
Oh, we're good.
That's just the washer in the background.
Yeah, we're fine. We're fine.
Didn't have a marked loss of spinal motion. Had no detectable loss of lateral spinal motion. But 20 extensions in lying. Significantly decreased the pain with squatting, started to show some increase in motion, but the patient also had a rotator cuff problem, 3 minutes of sustained lumbar extension, knee range of motion is full, and squat is pain-free.
Which that always, we've asked some of the other MDT instructors about what I'm about to ask you, which is, when we're talking about derangement, do you necessarily have to have a movement obstruction in the spine? Sounds like this patient's spine moved relatively well.
Yeah.
So in the classification of derangement, one of the components of that is movement obstruction. Where I'm going with this is, what is the potential mechanisms? Could it also not necessarily be like an internal disc disruption? Could it be more of like a neurophysiologic reason that we're in range moving their spine and getting a result? And I know the answer is going to be, we don't care. It is what it is, and you moved it and they got better. But what is your opinion on that? Like the mechanism, if you had to say, and I mean, we wouldn't hold you to it.
I even kind of like get further away from the mechanism, but I see some people, some patients, and we've definitely gotten away from talking about the disc and the disc model. Full transparency, I talked about the disc model this weekend. I drew a picture of the disc, but
this is confessional. I'm still addicted to the disc model myself.
But every time I draw a picture of the disc now, I write a statement above it that says a derangement is not a disc, because as soon as you put that disc model up there, if you haven't got that on there, people start thinking, oh, disc, and if you fall in love with that model, you will lose a lot of your patients.
The thing is, though, it does motivate. You can use it for them to be motivated to actually do the exercise.
Yes.
So how do you keep them motivated if you're not using the disc model? Because like if we were talking about a press up, I mean, they've seen that in yoga. They're like, the disc model at least allows we
had a debate within the organization, within the institute, about do we drop the disc model, do we keep the disc model, and that debate is still active.
Raging.
And I am on the side of no. I think the disc model is an important teaching tool. Getting rid of it and having other kind of explanations, it was like it just doesn't make sense. Robin was adamant he believed it was discogenic, but I'm sure Robin would also accept other theories. And I remember a story, someone asking Robin, what would you do if somebody came up with a piece of technology that could identify the true origin of back pain, and 99% of it was facet joints? And his answer was, "I'd change the first 30 minutes of the class." Well, you don't need to do that much. Now, from the neurophysiological, I'm a believer of it, because you'll see patients, and there's no obvious loss. When you see that patient that I've got obstruction with extension, obstruction with side glide towards. I do some extension, the motion gets better, the pain centralizes, the lateral glide improves. It's like there's something in the way. It sounds discogenic. I'd probably bet money, and I think there's some research that would support that. Yeah, that is likely to be discogenic back pain. But I see other patients. Then you see that patient that's got loss of extension, loss of side glide, and they respond to flexion. In fact, the third patient that I saw this weekend, who was somewhere in the territory of mechanic inconclusive, she had just back pain, just pain over her back and a right side of her back and a buttock. She had previous sciatica. She had a 10-month history. She said everything got worse when she got COVID in December, which was a bit weird. She'd been having therapy. She'd been doing side glides. She had a subtle shift, and she got better, and she was doing pretty well. She stated to me that if she did a side glide against the wall, she had good motion. She had good motion into extension, and she described like 3 weeks prior to the class that she was 95% resolved. I can't think, did she do something? She played golf like 3 consecutive days. This is California, not Michigan. And then she said she sat on some bleachers at some game, and then the next day her back was terrible. Severe back pain. Everything got worse. Nothing in the leg. All right. So she was 95%, and I'm sitting there. Anyway, so major loss of extension, major loss of side glide towards the painful side, still has a subtle shift. And when I first looked at the shift, though, it was like, is that shifted? Is it not shifted? You're going to walk very, very slight. So I lay her on her belly first, and she's okay. Prop her up, and it's like, yeah, that kind of increases it. That hurts, that hurts, that hurts. All right. So she'd previously been doing side glides, and she'd gone back to doing the side glides, said it was hurt, said it was painful. 50 side glides. Produce not worse, 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 produce not worse. No effect. Right. It was like 15, get up, same. 15, get up the same. 15, get up the same. She did have a painful kind of awkward forward flexion as well. Every time I came back and did that painful flexion, same. Nothing changed it. All right, flex. Knees up to chest, flexion and lying. Flexion's a bit better. All right, flex in a chair. Flex it a few more times. Her quality of her movement in forward flexion was now relatively asymptomatic. She looked like her back extension was a bit stiffer.
Was the flexions changing the shift or not?
No, never changed it. So I thought, you know what? It looks like she's a little bit worse bending into extension. So I'm like, is this a derangement? I'm like, anyway, moving around. Cut the story short. I did flexion rotation with her. Flexion was good. Extension still kind of stiff.
Atomic bomb option.
Yeah, the next day, so she came back 2 days later. How are you doing? Flexion's a little bit better. So, if you extend her, it just hurts, but she's not worse. If you side glide her, it just hurts, but she's not worse. If I flex her in lying, her flexion is markedly better temporarily. So I even got to the point where I was like, all right, flex. Never made her extension worse. Her flexion out, this is like, feels great. It's completely asymptomatic.
How old was she approximately?
43.
43.
Had her just stand in the corner for 5 minutes. Within 5 minutes of standing there, she's already starting to stiffen up. All right, flex. All right, go for a 5-minute walk. Comes back, already, so she's just, within a few minutes of standing or walking, she's just falling apart. Never lastingly changed it. But I flexed her probably 100 times in a chair with overpressure, never got worse. Her ability to bend backwards, ability to side glide was exactly the same. Well, you sit there, go to the wall, do a couple of the, exactly the same. And then it was like just debating about, well, the history, is it 3 weeks? It's like, never produced any thigh symptom. So it was like, she has a bias towards flexion. I can't say she got better. She was better, but I can just make it, just stand there for 5 minutes and she would just fall apart. Just go for a walk for 5 minutes, she would fall apart. She'd come back in, do 3 flexions, and she would go from being very uncomfortable to bend forward, so I've got full range. And for the class, it was a great patient for the class, because they were like, what's going on?
Had she already been seen by somebody kind of trained in?
Yeah.
So you kind of knew that had kind of been.
Wait, I tell you, she'd been treated by this woman before, who was not actually on the class, who is credentialed. She's gone back to before, but yeah, she just literally came off this treatment, and she was just about to discharge her because she was like 95% better, and then just randomly she got worse again, and then she comes into the class, and from what she's describing, she has a completely different mechanical presentation, but she has a mechanical presentation that any extension side glide just is like, ow, something in the way, significant loss and very uncomfortable, but never makes it worse. Pure flexion, much better into flexion temporarily.
Well, I mean, what separates you from like a lot of other people would be that, like in that history, she said one thing that would have shipwrecked a lot of people. She sat on bleachers for a day and she was worse. So then, like, a lot of people with that history, they automatically become scared to, start in-range flexing, which that's where, I mean, I think, if everybody got better at the press-ups, well, we wouldn't be having this discussion right now because it'd be pretty easy. So, but I think, I think Robin McKenzie said the answer with the patient is you got to move them to find out what the... Yeah.
And the thing was, as well, when we got to the end of it, so there's a hands up who thinks it's a derangement. Everyone's hand goes up, and I'm like... What's the hallmark sign of a derangement? It should respond.
You just got to get better.
And it's like,
or worse.
It responds with flexion for 3 minutes, 4 minutes. And but actually, there was another same thing again. There was like another patient on there, and it was like pretty quickly during the history, I've got no back pain. I've got buttock and pain all the way down my thigh. It's constant in the leg. It's like I can sit, I can bend, standing and walking produces my leg symptoms. And everyone in the class. So what are people thinking? Derangement. Like, what else could it be? Mechanical unresponsive. Derangement. No, it's derangement. And I'm like, look at the big picture. It's like she can sit on the recliner and watch movies for hours and be completely fine. Stand up, close down on the canal. Yeah, my leg's hurting. Sit back down again, it goes away again. Took some steroids, that was helping, and it was like, yeah, but that's the thing. Is so for the first part of these classes, it's like, what is a derangement? And then the next part is trying to pull people away. No. Get away from the derangement. It's only a derangement when you determine that it's a derangement. But then people just get leg pain, derangement.
Right.
Yeah. So what about that first patient that you just told the history of? What do you think would change? Let's say she's in your clinic here. She sees you for 3 weeks straight. Where does that case end up?
The patient with just the back pain?
Yep.
We talk on the class, it's like pattern recognition. Now, I've seen patients like her before. Mm-hmm. She has a bias towards flexion. She's got just back pain. She's got no neurological deficit. Mm-hmm. Technically, she's only really had this problem for a few weeks. I'm anticipating as I continue down this flexion pathway, her tolerance to extension side glide will improve. Now, I can't explain the pathoanatomical physiological mechanism of that, but I've seen patients like that. She can rapidly restore her flexion motion with a few flexions. Mm-hmm. And if you actually want to put it into anatomical, any closure is miserable. Now, we're not talking about closing on the nerve because we never had any nerve, but any closure on that posterolateral joint is miserable. Any opening feels good, mm-hmm. and if you do a few moves in that direction, I am better. I'm just short-lived better. Mm-hmm. I'm anticipating, partly hoping that, right now within 5 minutes of standing, it's already falling apart. Mm-hmm. I'm hoping 5 days of doing this, it's 10 minutes, 50 minutes, 20 minutes. I'm hoping, it's a major loss trying to go this way and this way right now, but in the next few days, I'm starting to see I'm getting less sensitive in that direction. But I don't know.
Yeah. Mark Miller told a funny story. He said, he's like, I've been teaching a long time. I've seen a lot of patients in this seminar format. And he goes, I would be lying through my teeth if I told you that when I saw that patient the next time that I wasn't like rooting for them to be better, So in that case, were you pretty confident how it was going to come back, or did you?
After the first day, because I felt like she got worse going into extension, and she did like flexion rotation, and I immobilized into flexion rotation. I sent her away with that. She said she felt about the same. Her motion into flexion was subtly better, but the patients are saying, but it's minimal. And the thing is, though, I could also make that flexion worse within a few moves. A few side glides, and it's bothersome again. A few extensions, it's bothersome again. So mechanically, she was about the same. Now with her, from what I saw in the clinic, I wasn't really anticipating anything. I wasn't really surprised that she came back like she did come back. But she was a great patient because, it would hurt to do something, but so temporarily, and she was one of those people that you can just do 2 more of those. Yeah, okay. So just do it.
And Robert,
and you could test. And the thing is, we could do. I'm going to try this again, and I think it's going to make you worse. Yeah, it's worse. But we also knew, because I used to do 10 of those. Well, maybe I don't need 10. Do 3 flexions, and she was good. Mm-hmm. So okay, just do 3. But I want you to do lots of those over the next few days, and I'll be following up with the people at the class because I'll be kind of interested to see what happens. Mm. But I'm kind of expecting that her tolerance she will trend in the right direction. I don't think it'll be rapid like a derangement, but she will get better.
Yeah. Robert Metcalf, he always says when he taught our courses that he hates going flexion and rotation early because it's like at the end of the. Now, were you at the end, or were you just trying to do it to purposely trying to kind of expose?
Well, so I've got this person who's been treated before. So I saw a subtle shift, but I'm like, I wasn't buying it. So I said, well, okay, let me get you prone. Fine, prone extension. This kind of bothers me. This hurts. So, definitely don't like extension. All right, previously you felt like there was a shift, and previously you did side glides. Give me side glides. So it was like 10, 20, 30, 40, 50. I mean, we sat there, 15, have a walk around. So, but like, ow. And I'm like, we're just hitting this brick wall and getting nothing. So then I went to pure flexion. So I stuck in this. I kind of like start the sagittal plane. So I'll give it the benefit of the doubt. If there's a shift there, let's take a look at it. But then I'm like, is this even a derangement? And then I went to pure flexion, and pure flexion improved her flexion, but it did look like it worsened the extension. So doing flexion looked like it might have worsened the extension. And we're like, that's a little bit sore now. All right. So then I was thinking, okay, if there is a derangement with lateral that you can't get anywhere closing it, let's do lateral with opening, so into the flexion rotation. And then she showed some improvement with the flexion rotation, but by the second visit, my thought was, it's not the rotation that's helping you, it's the flexion. And when I came back to just do it pounding flexion, it didn't actually make extension worse, and it actually did improve, but the improvement was just so temporary.
And it was chair flexion or flexion in line?
Both. I started flexion. I started low load, but she's like cranking on it, pulling on the chair legs, and then it was like, and that was kind of I actually brought it up and says, I asked the group, I says, does she look fragile? Nope. We just did like 20, 30, 40, 50 flexions with overpressure. Flexion's better, extension's the same, but even the extension though, it's just like I keep hitting that blockage. I bend backwards and it hurts. I bend lateral and it hurts.
Do you think, and Scott, if he teaches, he talks a lot about Cloward signs and Cussledge's research and how radicular symptoms don't necessarily have to be because the disc is sitting on the nerve root. That was the first time I heard that. It was just, I just haven't thought that way. How often do you think that is happening, or do you even believe that?
So you mean the referred versus radicular?
That's probably a pretty good distinction to talk about. Yeah.
Oh yeah.
I think think if you have any symptom that's going that you would have to have like mechanical pressures or even chemical.
Oh no, I don't. I'll have to disagree with that. Yeah. I think I see a lot of referred symptoms into the extremities that are not radicular at all.
So not like a mechanical pressure,
nothing to do with the nerve root at all. Not a compressive lesion at all. Yeah.
Yeah. Okay.
And me and Scott have been teaching a lot, so we pull out with the part Bs, we pull out the cloud signs, is a huge and that's a huge indicator with regards to shoulder versus neck. I got shoulder pain. I'm here for my shoulder. Where is it? It's back here in the shoulder blade. No, that's your cloud sign right there. So it's anything down in your scapular region, it's like this is probably cervical, if not cervical thoracic junction.
Right, but not necessarily mechanical pressure on the nerve root. Just the disc can refer into the shoulder blade, and that's like an important point that I think people.
Yeah. Oh, absolutely, yeah. In fact, I'm not very good at quoting literature, but I can quote this perfectly. Conor O'Neill, from 2000 and something. I remember because the Irish bar in town's Conor O'Neill's.
Word association.
But Conor O'Neill demonstrated, he did a couple of studies where he actually just did annular distension. And annular distension without nerve root compression would go all the way down the leg. And the other interesting one was actual the facet joint capsule distension, and that would refer down the leg in a centralizing, peripheralizing pattern. It just would never go back to the midline.
Do not tell me that the SI joint refers down the leg. Just checking. No,
that's not good. A little bit.
It could.
It could. But
the research
but
says that it can, but it doesn't seem like clinically.
I think in our PowerPoint, I think we talk about like generally it's here, but it can have the capacity to go into the thigh, but not very far.
Right.
I mean, I'd be very, I'm very. As soon as I see something go into the thigh, I've already stopped thinking about the SI.
Right. Same.
So you kind of mentioned the Cloward signs of cervical spine. We're bringing in our first ever listener question. So a very special previous guest of ours, Jay Gallick, brought up a great question I thought for you. So when in regards to cervical spine, we've heard people, basically every guest say, 20% of the time in the cervical spine, I'm going some sort of lateral component, whether that's lateral flexion, whether that's rotation, some component like that. First question is, do you agree with that 20% in your practice? And then the second question would be, what are some hints maybe in the history or in like the mechanics that would say, I have a kind of an inkling that I may need to go lateral here, or I may need to start some lateral forces there. And not the textbook definition. I'm saying like your clinical stuff. I know.
Yeah, for number one, I'd probably agree with her. I would say, I mean, I see, I see a good, I'm looking at not rotation very often, but laterally. I don't see too many rotation. I'll come back to another thing with rotation. I've seen a couple of interesting patients with rotation, but lateral flexion. I mean, what indicators? I mean, I suppose the textbook is asymmetrical unilateral symptoms, asymmetrical movement loss. But I don't think, I can't really think of anything off the top of my head that would sit there going, this person's going to need lateral.
Mm-hmm. Except for a right neck or
obviously someone coming in with a right neck. But in the we talk about like in the lumbar spine, the patient that I get worse when I sit, and I also get worse when I stand and walk. Mm-hmm. Okay, you've got a kind of a vulnerability to both directions. The cervical, no, I don't think there's anything necessary in the history. And even in the clinical presentation, because I tell people, I see so many patients with loss of right rotation. You do a bunch of sagittal moves and fixes the right rotation. Right. It's going to be more down when you get into the actual physical exam and you start moving the patient. You see that asymmetrical movement loss that either gets worse when you start doing these types of things, or if it's just like zings down into the arm or something like that. I think it's more the physical exam that just takes you there, rather than the history. But I do the lumbar spine probably a bit more.
Yeah, 50s.
The patient I sit, it gets worse. I go for a walk, it feels better initially there, then it starts going down here. Okay, I might be more inclined to kind of go towards lateral with that.
And do you feel those patients that are responding to lateral in the cervical spine, do you feel that is the only movement that is going to produce the miracle that we need in that case? Or do you feel like, if you 3 weeks later, if you were taking them down the sagittal plane route, that they would eventually come around?
Potentially.
Right.
I think it's one of those things. It's like, if I've heard from clinicians, you're talking about like the 20%, the 20-ish% of patients who go lateral. I might be in that group of clinicians. I have that. And why do I have that? Because maybe it's because I get, I try and move things along quickly.
Quicker result.
And I'll say, I'm going to get in there. It says, this is starting to bother me. Screw it, let's go. Let's just start doing it. Whereas I know some clinicians will sit there and say, no, I'll give you a few days with some mid-range retraction. Mm-hmm. And I'm like, I'm a bit, let's move things along a little bit quicker.
I think that exposes what it is. I think you're probably getting your result a lot quicker by going there.
Yeah. So it's it's one of those things. It's like, and maybe and I think as well because it's, I just talking with Scott and it was like a lot. It says I don't even need a table when I'm treating a neck. I'd rather just do it in sitting. Mm-hmm. You get into a debate because it's like, what if exhaust the sagittal plane? Well, exhausting the sagittal plane technically is unloading and also going into distraction. Yeah, but as soon as you start putting your hands on them, lying people down, the actual home management gets harder and harder and harder. And sometimes you can kind of like cut the corners a little bit. Well, this is kind of bad. You know what? It's pretty easy just to kind of throw in a few of these and see if anything good happens. And if nothing good happens, then we'll go back.
Sure.
But if something good happens, then all right, we'll remember that for the few days.
If I changed the question and I said, okay, all your cervical derangements over the age of 60, would you still keep your number at around 20%, or would that change it?
Over 60. I don't know. Off the top of my head, I don't know. I might be a bit more inclined to say less likely.
Right. That's what I would expect.
I'd probably say that. I mean, if I think about those patients that I'm mobilizing or overpressing into lateral flexion, it tends to be kind of the younger crowd. Yeah, I'd probably agree with that.
Okay, perfect. So now we've talked about the spine. Have you ever seen the show on ESPN? It's called Pardon the Interruption. Do you know what that is? No. They basically take a topic and they'll talk for like 2 minutes, and there's basically a buzzer. We're not going to have an obnoxious buzzer, but what we're going to do with you is we're going to talk about the main extremities. So we'll throw out an extremity joint to us.
All right.
You tell us what the main, like how you're going to work your way through the different stratification of derangement, and then, because a lot of our listeners will already know that, but like we also then want like some clinical pearls.
Yeah.
Okay.
One or two.
Like you
things
told
in that
when I
area.
was with you last time, like you said something to help me out a lot, because I wasn't finding, for example, many people that were responding to hip adduction derangement.
Yeah.
And you already told me, you're like, yeah, I never say it. So I'm like, and like you just tell me that.
I just dropped it. Yeah. In fact, this weekend it's still one of my pictures of my PowerPoint. I'm like, yeah, adduction.
Break.
Just not seeing it. I mean, it's funny because you go through these little phases and it's like, yeah, I saw that a lot and a lot and a lot.
I know, weird, yeah.
And then all of a sudden it's like, it's not there anymore. And then
Right.
you kind of keep going back and looking and going, I'm not really seeing that as a common thing. But there's also, it's interesting as well, when you start looking at things just start to shift. And I remember years ago at one of the conferences where we had like early on when the extremity textbook was just coming out, and we had a few kind of little breakouts, and people in actually talking about, like, you know, the cervical. If I stuck with this plane, would I have gotten better, or would I absolutely have to need that? I'm a believer that there's probably more than one direction of preference in a lot of extremities. Because and I think you just naturally, you see patients and you become a bit biased. And you go, you know what, this worked before and worked before and worked before and worked before. So you start going down that. Then you go, oh, the key movement for this joint is this, because I use it all the time and it works all the time. And then the next person who, I tried this and then I tried this and I tried this and I tried this and that works all the time. And then you like get together and you go, really? Oh yeah, I see. This is I never use that. I don't use it because I'm using this one. And you know, when if you're rotating a joint in one direction, maybe the other direction would do. But if you naturally go, well, the shoulder, for example, I look at extension, look at internal rotation. Well, if that mops up most of them, then I don't get the opportunity to explore other things. I should probably sit there and say, you know what, every shoulder I see from now on, I'm going to do flexion and external rotation, and see how many of those actually kind of respond. And you might find that there's actually a bunch of them who do respond.
All right, so not everyone who's listening is MDT trained. So maybe just to set the framework. So we learned through Audrey Long's paper in spine and others now. I'm told there's over 60 papers that are saying that we should be looking for a directional preference, not only in the spine, but also in the extremity joints. So I guess it's such an important thing. I mean, I think it's a little more obvious in the spine, but you can get all the miracles you get with the press up in the low back, you could potentially be getting the extremity joint. So we'll kind of set the table with that. Mm-hmm. And then, do you have a favorite joint in the extremity? Is a jump off point or not?
Oh, favorite joint. Shoulders and knees.
Let's start with shoulder.
Shoulder. Okay. So you're going to get, I'm going to kind of cut you off after a couple minutes. You're going to take a couple minutes. We want to know maybe the top 3 directions in your order, and then 1 or 2 clinical pearls per area.
Oof.
Okay?
Man, killing me.
So we're going to start shoulder. Are you ready?
Yeah.
Ready, set, go.
So shoulder, I mean, the 2 big key movements are internal rotation and extension. Mm-hmm. Internal rotation got very popular early on. I'm probably a bit more inclined to say extension is a bigger move than internal rotation.
Scandalous.
Mm-hmm. The other key thing is that typically the answer is back here when there is loss in elevation and back here. But if there's loss in elevation but no loss back here, horizontal adduction is a big move. I think probably the key pearls and the things that early on it was like we get a derangement and it's gone. That is probably less common. There are a lot of derangements that probably to fully reduce, it's more of a protracted time frame, and you're going to get there with progressions. And I think people kind of get stuck and start doing one thing, and I'm just doing this. Does it help? Yeah, it helps, and they just kind of stay there. Once that patient plateaus off, we want to push them a little bit harder. And probably with teaching extremity classes and just kind of like having taught extremity classes for going on 10 years now, something like that, and actually seeing how those classes have actually kind of evolved, probably the two or three things that are probably often overlooked in the progression is the use of sustained and the use of resistance.
Love it.
So you would get to extension over internal rotation simply by you're checking both, and there's more movement obstruction in one. That's how you're getting
yes.
it. Okay.
Yeah. So I've got pretty much all of these shoulder derangements. There always seems to be loss of elevation, and if there's a greater loss of extension than internal rotation, go after that one.
What's an easier, like let's say you got an older patient, you're going after shoulder extension, like the squatting, all that just a little bit awkward for them at home, like
golf club.
Just simply
a 4-iron.
Okay.
This direction?
Yeah, no, because I like palm up. So basically, you can hold onto a long iron and then just have them kind of push back.
Nice.
Just make sure that they're not bending as they go. But the patient that can't squat down and can't do that, so that's a nice way to do it.
Is a normal range of motion you'd put it at like 85 or 90 degrees of shoulder extension?
Oh, it's so variable.
Yeah. Okay. Don't even.
Compared to the other side.
Okay.
I see some people like 45 is them. I see some gymnasts where they're over 100. Just make sure you get.
When do you go? When do you start with flexion? Do you ever start with flexion? No.
Okay. Do I start with flexion? No, I'll go to flexion if I get a red light with extension.
Okay.
Brett's crushing our 2-minute idea here.
Sorry,
Asking stupid questions. So come on. All right, knee.
Extension. Probably say. Though Richard Rosedale probably be mad at me because he did a study looking at older knees and there was a lot more flexion biased.
Mm-hmm. I find a lot of flexion bias.
But I think, and I do see that in the older degenerative knees.
Yeah.
But I see the majority of them respond to extension, and my clinical pearl is I use a lot of resistance. I start with some active extension. Pretty quickly I get them up into a loaded position, but I do like doing it with a TheraBand.
And then TheraBand pushing down into further extension?
Yeah, yes, I actually have the TheraBand over the front of the knee and the band is behind them. So I get a big loop, trap it into a door jamb, they step in. So the extension is their direction and they are feeding the knee into extension under the resistance.
Beautiful. We made up some time there. That was pretty easy.
And then how often are you going like rotational things?
Some. I like doing some. If I'm not getting the response with pure extension, but not massive numbers. But yeah, external tibial rotation going into extension is.
Yeah, got it. Okay, let's go back up to the upper extremity. How about the elbow?
Elbow, extension and pronation.
Pronation in mid-range pronation? Yeah.
Pronate and going into extension. Pronate and going into extension is a big one.
Okay.
Also with the elbow, a lot of it's progressions. I do some resistance going into extension with the elbow, but then also ballistic. Ballistic is when I get to extremity classes and people are like, and the things that I see people not using, ballistic elbows, ballistic dorsiflexion, occasionally ballistic knee, but ballistic hip.
Mm-hmm. Scott talks about ballistic hip extension.
Hip is a big hard joint and rotation. Yeah, doing like the thoracic rotation with the hip.
Beautiful. Okay, that was good. Well, you just talked about the ankle dorsiflexions. Let's go ankle.
Yeah.
Can I ask one more thing on that before we move on?
I guess.
Lateral condylitis. How often do you find it actually to be a contractile?
80% derangement.
80%. You heard
No,
that?
actually. Okay, I'll rephrase that. 20%, I'd probably say, is a contractile problem.
Okay.
In my clinical practice.
Right.
I see a bunch of derangements.
Right.
But then I also see a bunch of necks.
Right.
So I'd say if somebody comes in here with lateral epicondylitis, it's statistically more likely not to be.
Right.
In the one thing with the derangements, it's a real simple thing. I just have the patient stand there and say, "All right, can you just straighten both arms?" And then give them a little overpressure. And if they go "ow" or they go,
Yeah.
I'm like, "All right, contractile dysfunction just left the building."
Well, there's
Go
actually
already.
really good class 1A evidence on cervical spine manipulation for lateral condylitis, which
Actually,
is
thoracic is, I think, upper thoracic as well.
thoracic
Yes.
too. Yeah.
Yeah.
So, but yeah, to your point.
Yeah, and I've gone there.
Yeah.
And I'm sitting there going, "Yeah, you're doing this," because it is also, yeah. I mean, there's there's a big debate within the institute about screening the spine and what do how do you go about screening the spine. But yeah, when you also get down to that lateral and even medial elbow, is you got to start thinking about upper thoracic.
Yeah. Wow.
Beautiful. Ankle.
Dorsiflexion. Dorsiflexion, push it hard, loaded, and ballistic. Though I still talk about this on classes. On classes, it actually reverses, and it's more plantar flexion. And there's a reason. Most of the people that come to the classes have been treated. And if anybody's treating an ankle in a physical therapy clinic, they are doing some form of pro stretch, stuff like that. And if they get better, they wouldn't come to the class. And if they don't get better, they go, "Oh, send them to the McKenzie class."
Are you doing the kneeling plantar flexion, or what's your best way of loading plantar flexion?
I do the off the edge of the table. I've actually got it's going to be more than 2 minutes. Let's see if we can get this out pretty quickly. I like the table one. I've had a couple of patients that needed plantar flexion, but it had to be loaded.
Let's let them go beyond 2. Do you mind doing a demo of what it looks like?
The actual load. Well, if I'm doing just pure plantar flexion, I'm doing it like this: pressure on, pressure off. But I had a patient that the only way I worked out what was going on was that she was all over the place. I couldn't work her out, and then she told me that she went to a black tie dinner and wore stiletto heels for 3 hours, and she got home and she walked around and she was pain free for about an hour.
Yeah.
And I'm like, "Well, you're down this position." So I'd done all this. I plantar flex, I dorsiflex, I twisted and turned. So I ended up getting her going into plantar flexion and actually using the other foot to push it all the way over, because the only way it would reduce was in a loaded position.
And then, do you always stay pretty pure to the McKenzie way of doing these movements, or would you ever use a slant board? Or,
Oh, yeah.
Yeah. Okay.
Well, the thing is as well, I mean, pretty pure. I mean, the spine's pretty pure.
Right.
If you actually look at our manuals for the C&D manuals, we've got in the extremity manuals, they've just taken pictures of everything. There's no true formal procedures or anything like that, and it's like, we're moving a joint. How do I get that joint moving in the direction I want to do it? And then it's just thinking about does it need to be loaded, unloaded? Does it need to be under distraction? Does it need to be ballistic? Does it need to be speed? Does it need to be sustained? It's just working out those things. But the fun thing with the extremities is playing.
Right.
It's just like playing around with them, and then but also kind of keep pursuing it, because I nearly lost this woman, and then it was like after having a terrible time, 2-3 weeks later she's asymptomatic, she's back running. But it was just one thing that kind of caught my eye, and I'm like, oh, that was interesting. And in fact, I've got one more ankle one, which was actually another interesting ankle joint. Doing a gastroc stretch felt good, but didn't make her last any better. Doing loaded dorsiflexion made her much worse. Doing loaded plantar flexion made her much worse. Couldn't run. Young 20-something year old. keep coming full circle back to just doing a gastroc stretch. And when I say stretch, on, off, so kind of a loading, would make it feel better, but never got it better than what she wanted. And I'm like, okay, so she definitely doesn't like plantar flexion. She can't tolerate end range dorsiflexion, but likes this kind of mid range dorsiflexion. And then I'm sitting on a cloud going, let's try this. And I just started doing active resisted dorsiflexion. Bit of TheraBand, have her pull up against the TheraBand 20 until you're kind of fatigued at tibialis anterior. And then she gets up and she's like, it's great. And so she needed dorsiflexion, but the only way it would work was actually if it was resistance, and she had to kind of pull into that dorsiflexion.
That's random.
Yeah. Oh yeah.
That's called
I love it. No, I love it.
There's a randomness to it, but it was a great one because it was like it was just kind of working out. Definitely worse that way. Did not tolerate that, but kind of likes a bit of dorsiflexion, but not to be pushed. No loss of inversion, eversion, supination, pronation, so I didn't even delve into twisting the ankle.
But typically, you would exhaust dorsiflexion, meaning you're using repetition, you're using sustain, you're using ballistic, and then at that point, and this is all.
But I did that, and it red light.
Right.
All right, hit a red light, go the other way. Oh shit! I got a red light here as well.
Right.
And then I'm like, well, go back to what you liked. And what she liked, this mid-range, she's doing this on and off with this. So it's not end range. It's kind of a mid to end range. And that got her back to baseline. I made her worse, got her back to baseline. And I'm like, well, do a few more of those. And we did 20, 30 of those. And still, it's not further better. So I'm like, well, definitely worse. Didn't tolerate that. How do I move her there under a different loading strategy? And then I just got some therapy. Well, try some therapy.
Love it.
And it responded very well.
Hip and wrist, right?
Hip, wrist, and TMJ.
Okay.
We're going wrist.
Wrist, who knows?
Yeah.
It's Joe Maschio's study. He's seen more wrist in that study than I've seen in the past 2 years. But it's hit or miss. But I don't tend to see too much lateral. Mm-hmm. I'd probably be a bit more 60-40 towards extension.
Okay.
But I just don't see enough of them. And we always, when I talk to people about wrists, it's like, not seeing a huge bias with them.
Although Mark Miller said something interesting in our podcast. He said, because he does see a lot of wrist with what they do.
Oh, yeah.
And he said that, he goes, I cannot remember the last wrist complaint that I saw that was not a derangement. And it really made us all think. We're like, wow. Okay, yeah. So interesting clinical pearl.
Because we're with you. They're just tough to treat. That's just the reality.
Yeah.
So, okay. So then let's go to the hip. We'll finish the TMJ.
Hip extension, internal rotation, and in fact, maybe even biasing more towards the internal rotation than extension. But it might be just the patients I'm seeing, but I can see quite a lot to respond to that. Again, sustained and ballistic.
And why do you think internal rotation at the hip? I always wonder this because usually the directional preference makes perfect sense. You would kind of think that people's hips spend their time in internal rotation. Who knows?
Yeah,
maybe anatomical.
Yeah,
who knows?
And I had a hip recently, and their loss was external rotation. There was a greater loss of external rotation, and doing some external rotation is just aggravating things. Get on the floor and have them twist, and it's like, oh, this feels good. And then it's also interesting as well because you'll see those patients where there is a big loss of internal rotation, but you get them into kneeling and have them do it in a loaded position. They've actually got a lot more motion when they've actually loaded.
Love it.
Interesting.
Okay, let's finish with the TMJ. Brett's favorite.
TMJ. I think the direction, the complaint that the patients that I see is opening. I can't open my jaw. Protrusion with opening.
Right.
I think is the key direction. Having the patient, I always kind of joke, says, I'm teaching a TMJ when I go into the room with some hand sanitizer and a box of tissue. because I'm getting them in there and getting them pull and open. I have seen a few where you've got lateral loss, and I've actually had them actually go towards the obstructed direction and then open. And I'll be interested to see if with COVID, if there's a change, because I mentioned before we started the podcast that I had treated a dentist, and she did not tolerate protrusion at all, but she actually reduced with retrusion with opening. So it's hard to do. You have to get to relax the jaw, but actually push back and then open. And she responded very well like that. And then she actually sent me a patient and who was a saxophonist who also responded to that. And when I was talking to her about it, it was like, well, when a saxophonist, if I play saxophone, I guess they kind of hold their jaw in that position. And then this dentist also told me that she wears a mask all day, and she keeps protruding to push the mask away from her. So maybe we're going to have an epidemic of TMJs that are going to need retrusion.
That is 100% true. Like if you're wearing a mask, you can feel yourself protruding.
You kind of see people doing this all the time, and it was like, I'd be interested to see what happens with that.
Right, love it, awesome, great job. We crushed all through them. So, man, any last thoughts, Brett?
Just we forgot to introduce your clinic, so thank you for
Plymouth Physical Therapy Specialist in Ann Arbor.
I love it.
3256 Washington. Yep.
I would also say everyone throws out kind of the same 4 or 5 names as far as people that you have to see if you're taking the MDT course, and your name's always one of them. So
good.
It's a privilege and honor. I've sat through one of your courses. You did an amazing job. So what an honor to have you here.
Well, thanks very much.
Thank you very much.
Yeah, it's always a pleasure.
Time to drink some good wine.
Yeah, that's right. We got reservations, and I'll be a decent steak in our future.
Oh yes, yes. Can't go wrong with the chop house.
That's right. Awesome. Well, guys, I think like at the end of the day, every time we sit down with an MDT instructor, even Brett and I do deep dives when we're getting our credentials and stuff like that. I think at the end of the day, just like be persistent in your assessment and be persistent in your treatment. Like if you get so taken aback by all the noise, you sometimes miss the miracles in your day, and derangement is a miracle every day.
Oh yeah.
I think too, to be curious, you kind of alluded to that a little bit, and Scott's good at that too, like just to keep playing a little bit, especially in the extremity joints, and expose it. Yeah.
I mean, I don't know who coined the term, but it was like searching and destroying the derangement.
Yeah.
Oh, one final thought. Give us your best Robin McKenzie story.
Oh.
We'll finish. They'll be perfect.
Yeah, that's
perfect. My best Robin McKenzie story. Well, I mean, there's kind of two stories, I suppose, because I first met Robin back in 2007 at the conference, and everyone's come up to him, and there's like 150 people. Hey, Robin, I'm such and such, and I'm such and such, and I'm sitting there, and I'm like, hey, I'm Dave from Man. Oh yeah. And the guy's like, he's in his late 70s at this point, and everyone's just kind of like clawing at this poor guy. And I'm like, I'm not one for clawing. I took a bit of a kind of a stand back and just let him do his thing and stuff. And I mean, I'll tell you how it happened. So we were sitting there. So I was hanging out with my friend John Thompson, who was the faculty in Scotland, in the UK, and they brought him a bottle of whiskey. They had it sent up to his hotel room. So he came over to the table, and I think Jenny Ross was there, and it was just like this thing. It was like a hierarchy, and at this point I'm at the bottom. I'm down here right now.
But you had whiskey.
Yes. So anyway, so he comes up to somebody, and he's like, "Oh yeah, thanks for the whiskey and stuff," and and then he goes to my friend John Thompson. And he goes, oh yeah, hi, John, and he's like talking to John Thompson, and he says something like, oh, you're from Scotland as well, yeah. So he said, well, first he said something, what clan are you? And he says some clan, and he goes, oh, I think we beat the shit out of you. But anyway, but he went from one person to John, and then he looked at me, and then he never said a word. Anyway, but then it was kind of like, so then me and my friend John were kind of just joking about it, going, I says, he knows Jenny because Jenny trained with him, and he says he kind of knows you, and he didn't even give me the time of day. Anyway, so it was like, I think it was like there's like a cocktail hour a little bit later and stuff, and he's kind of circling through and stuff, and then I introduce myself to him, and I'm like, hi, Robin, and says, yeah, I'm one of the US faculty and stuff, and then John was standing next to me, and he looked at John and goes, have we met? So it's always like stories like that.
Classic.
It's because when I was training to be faculty, I'm hanging out with Mark and Scott, and they're talking on courses. Oh, I was talking to Gordon Waddle at this course, and I was talking to this person at this course, and I'm like, no one knows me.
Right?
Love it. Yeah,
but now here you are, though.
But the good thing was it was like I presented at the conference in Rio, and Robin was planning on coming to it. But he'd had a stroke and he kind of recommended it. But I was in like a little kind of communication thing with him, and I actually there was like me, Colin, Scott, Mark, all these kind of people and stuff, and I actually emailed him a picture of me. And I actually wrote in the thing. He says, "You've known all these people for ages. I just want to make sure you remember who I am." so the good part of it was, when he passed away, I passed away. Everyone knows Robin McKenzie, but I've got that little thing. Well, he kind of knew me as well, a little bit. Just a little bit.
Just a little bit.
Yeah,
I love it. Awesome. All right, we gotta get to dinner.
Awesome.
Good to see you guys. All right, later. Good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.